إيلافهم رحلة الشتاء والصيف فليعبدوا رب هذا البيت الذي أطعمهم من جوع وآمنهم من خوف صدق الله العظيم.
I would like to call Dr. Saad Khalid Niaz on stage, if he can have a few words.
Bismillahirrahmanirrahim. Started with Waqar and then and Khalid and now we have this. So I'd like to welcome you all. First of all, I would like to thank the faculty, international faculty, starting with Dr. Waqar Ahmed, Khalid Hassan, Mustafa Rai, Dr. Nadeem Tehami, and shortly Dr. Yasin Nabi Tayyib, who is from Lahore. I'm also very grateful to Dr. Laik, who has joined us from Makkah, and Dr. Mansoor. Professor Mansoor is head of gastroenterology in Liaquat National Hospital and is joining here. And he's been they've both been supporting us throughout. So we're very fortunate to have a lot of friends. Dr. Nawal said it's the only course. No, it's not the only course in hands-on course, but there are some features that are unique. These courses we've actually copied from or practically taken from the UK. Hands-on means hands-on, that's why you've only got, this is an exception, this time we have 6 candidates, otherwise we take 5 candidates nationally. And it's pretty intensive for the trainee as well as the trainer, because in the next 3 days we'll go through, with 6 candidates, we'll go through at least 24 ERCPs. And during those ERCPs, 4 you will be actually doing yourself, but the rest you will also be watching. So, and it'll give you perspective from across the Atlantic, from UK, from Pakistan, and also Pakistan, different centers. So I think this is pretty unique thing about the course. What I already told you is that the faculty is very friendly here. We are here to teach. They have traveled from far distances, arrived last night, and are here in the morning. I must add here, unlike most courses in the world, we don't give them any honorarium. So there's nothing given to them. If they're lucky, they'll get their fare, hopefully. So we are really in debt to our international faculty for not only taking time out, but also actually, doing it voluntarily. Now, before we start, I just wanted to, because this is the first time, I must welcome Ilyas. Where is the name here? Where is the bacha here? We have one candidate, Dr. Bashar. Bashar he's from Jordan. Dr. Bashar, in between, our own language will creep in. If you don't understand or you miss something, please do ask. We'll try and keep it in English so that it's easy for you, but sometimes we have to explain or talk in our language, which I apologize in advance. So quickly, what I wanted to do was tell you a little bit about what SIAG is doing. Ajay, slide later. So this is a cashless facility, so we don't have a cash counter here. Okay, so everything that's done in this facility is done without charges to the patient. And the way we fund ourselves is basically by the government and the philanthropists in the city. So there are 3 elements of what we wanted to do when we set this up. We've been working here since 2006, but in a very small 3-room setup. And we started these courses then in those small rooms. with a single fluoroscopy setup, and it was very tough then also. So our three main aims were: one, service to the patients of quality, and for them not to realize that this is free. So if you look at our logo, it says Mehari Ilaj, which means quality treatment, and Izzat ke saath means with respect. So we didn't want our patients to feel that this is a free facility, so we are doing a favor to them. I strongly believe that in our facility, and probably most, otherwise even if you're charging, the patients are the ones who are actually providing for us. So we should be thankful to them rather than otherwise. And it is more true for our center and the employees here. So the service aspect, I'll just go straight to where is the so anyway, so in the first year, which was 2024, we did about over 10,000 procedures, of which 2,500 were ERCPs. We did about close to 600 in some EUS. That time we had a single EUS system, and now we have EUS in both fluoroscopies and also EUS lab separately. So the numbers are growing, so this year we've already covered that. We did over 100 spyglasses. I think last year we did about 130 spyglasses. This year we'll probably be touching 180. And that includes biopsies and EHL. Our EHLs have gone up, and that's because we found out how to make the EHL probe cheaper, and practically that's what allowed us to now use EHL in anyone we want, practically. Along with that, we've also introduced RFA. So we're doing RFA both EUS as well as for biliary bile duct as well, and the routine work. We recently started, 2 years now, we started POEM, so we do about 1 or 2 a month. The other aspect was training, which is why you're here. And we have fellows, advanced endoscopy fellows with us, and we have research fellows. And fellowship is for 2 years. And research is for 1 year. And for obviously those who join us as research fellows, there's a very strong chance that they would actually they would be preferred for the fellowship if they've shown that they are capable of it. So that was the training side. So we do 1 ERCP, 1 EUS, and 1 or 2 colonoscopy courses here, along with some workshops. We also do short fellowships. So of late we had somebody from a place called Bajor, which is north of Pakistan. And I can tell you now that ERCP services in Bajor have started. And so we pick up candidates. We also have an international fellow who's not here, who's a Palestinian, and he's the first international fellow that we have. So what are we doing? The third aspect was research and development. We're very small, so in terms of budget as well as in terms of what we're doing, but we have actually gradually developing our research side. So we have observational studies. We're also working on experimental studies now, clinical trials, drug trials, and we have just recently been approved by the Drug Regulation Authority of Pakistan as a drug trial center for both devices as well as for medicines. And we've also started registries. So the first one we started was a pancreatic registry, and that's through RedCap. we have about 13 retrospective studies that are being done. 2 of them have been accepted for publication. We've submitted, and there are about 10 that are ongoing. 2 accepted and 1 submitted and 10 ongoing. There's some prospective work done, about 6 of them. 1 has already been submitted, 5 are ongoing, and case reports. We'll just quickly share the trials. So observational studies that have been published are basically our ERCP, close to 13,000 patients. That's been published. Endoscopic ultrasound guided anomaly that I... Oh, yeah, Azad? I'm sorry. I'm sorry. I thought it was coming. So you can see, ये दूसरी वाली पे please आ सकता है Azad? Thank you. So I was just mentioning we did some observational work, experimental studies, which is one devices as well as drugs, and registry. We do a lot of pancreatic work, and both adult and pediatric pancreatic work. Of the ERCPs, we do about 10% of them are pediatric. And we're supposed to do one today who's 15 months. So, we so just touching on the observational studies, published 17 years of our work, retrospective work. The interesting case report on a rare anomaly, duplication of extrahepatic bile duct. APC for trapezoid basket, some of them you have seen, it got stuck and we use APC to break the basket. That's also been published. And EUS, guided pancreatic pseudocyst drainage in pediatric population. Submitted for publication, vascariasis, PEG placement we are working on with or without sedation, and PEG tube placement in post-sleeve gastrectomy. Ongoing projects, there's a long list. The interesting one that I think that we're doing is we're looking at and we'll share that a little bit more in detail, is the risk of infection because we are reusing accessories. So what we are doing is we do the standard cleaning that everybody does, then they are sterilized with plasma. And basically what we are doing is we want to find out how many of our patients actually how many of our accessories and scopes are actually contaminated post-procedure. And so there's a full trial going on, and that's a prospective trial. And other than that, I know in the West, you generally don't give antibiotics post-procedure. But here in Pakistan, majority of the centers use antibiotic post-PEG and post-ERCP. And the question was, do we really need it here or not? So we're actually doing that. It's a randomized trial. And so these two are very important. The other thing very interesting was use of diclofenac in pediatric population for ERCP. And we looked at the literature and it's not there. So we've actually specially made suppositories for pediatric population to see if it makes any difference or not. So there's some things that are going on. A clinical trial with hepatitis C, and now we're going to be involved in a trial with hepatitis D. The other part of the research is training models, development. So we made a model. This is a colonoscopy model, and we've actually looked at the British model, which cost £5,000. And this entire thing is made in Pakistan. And the difference between this and the British model is this also allows you to do polypectomies. So we can train you on polypectomies with this, and that, other than that, it's almost similar, and the cost is probably 1/10. So we've made, if you look on the left here, that's the model that you will be using. So in training today, you will have two models, one where you will be able to do sphincterotomy, and the other where you will be able to cannulate, wire exchange, stent, etc. This will be done on models before you actually go on. And I would like to have feedback from you to see if it was, if there's any other thing, in any way we can improve that. The point of making these models is because it's very easy for candidates that are being trained overseas to actually get hands-on or available. It's available to them. Whereas when we look at our setup, it's almost impossible for most fellows to go to US for visa reasons, or even now UK, plus the cost. So what our aim is to actually develop these, and then we're also going to share it with other units so that our trainees and fellows can be trained on these as it is elsewhere. So the other thing this is the training, these are the training models. We've also developed an EUS model. Other than that, we are also working on making accessories through our own setup. And so here you have the EUS needles. And FNB needles are expensive here. The Boston would cost approximately 150,000 rupees. Most centers in Pakistan, India, and I'm sure most are reusing these needles. They don't admit a lot of times, but I know that Indians do it 4 times at least. That's what I've been told off the record. And the same applies to Pakistanis, I'm sure. We don't use it. Here, we've stopped reusing almost completely. We worked on the needle for FNB. The easiest one was the model of shark. And the cost of just the needle is 1,000 rupees. And if we were to make this separately, I don't think if we had the plastic mold, it would cost us more than 15,000 rupees. If we had large numbers, the cost would come down. But the needles, if we just change the needle, which actually doesn't put a patient in any risk. If you just change the needle, you've taken the risk of contamination out or infection. It will only cost us 1,000. So we've actually looked at it. Samples are pretty good. I'll share it with the experts here and see what they say. We made our own pegs. Even mouth guard, the issue was that, at least what we see here is that the suction catheter would fall off many times. The guy is actually interested in what's happening. We all get involved. And the suction catheter, when you're trying to find, it's not there. So we've actually made a little opening. And the suction catheter goes there and it sticks on the left side of the patient just through a little opening. And then it's stabilized. So little things like getting polyp collection, this guide wire, savory guide wire, when we get it from Wilson Cook, it's costing us 18,000 rupees. This is made here, and this is 1,000 rupees. So this is something that we've been working on, and as I said, the aim of the institute was to do the 3 things that we are trying to work on. And obviously, the reason for telling you this is also for you to know, but this is our 3rd year starting. We've only done 2 years. This institute is only 2 years old. So if we can do it, so can you. It's about thinking and it's about putting your mind to it. Now, after telling you about this quickly, what we do is that we introduce the candidates to the faculty so that we know what your experience is. So I'll ask what we want to know from the hands-on first is where are you from, how many ERCPs you've done or assisted. You have a center to go back to where ERCP facility is available. For those who are doing, what is it that you're having difficulty with? Okay, so these are the 4 things I want you to tell me. And so we can start with Dr. Ilyas.
Sir, I'm from Multan. I'm working at Mr. Hospital, Multan, as assistant professor of gastroenterology. So I have done almost 3 ERCPs under surveillance and almost 10 independently. I feel difficulty in cannulation techniques, and I have no experience in placement of metallic stents in the CBD.
Why do you want to put metallic stent? I don't. It's very expensive.
They are very expensive.
By the time patients come to us, they usually don't have more than 3 to 6 months.
Yes.
So why would you want to put a
I
metallic?
have no experience as to gain.
So you just want to learn how to.
Yes.
I'm just questioning because I think it's different from where they're coming from, and studies might show that they are better. But for me, I don't, because I have to also look at my patient's pocket. Right?
Yes, they are.
We are very fortunate here. We have the availability, but still, we are very careful. We don't want to.
We are doing the same. We are only
Because it's just not possible, right? You're in a public sector hospital,
Yes, they are not possible.
so then you would be asking your patient to buy it. I'm sure.
Yes.
That's how it works in public sector.
Yes.
So just be wary of that. But we will try and tell you how to place a metal stent. This is a basic hands-on course, so we try not to go that side. But if there is a case where we want to put a metal stent or can put a metal stent, then we'll surely do that.
Okay. Thank you.
Okay. Dr. Bashar.
Thank you. Thank you for this opportunity. Good morning for everybody. I came from Jordan. I have my training in a busy hospital. I have assisted in many cases of ERCP. Our mentor, he is a hepatologist, and he was doing liver transplant. So I also assisted in some cases of this liver transplant. It wasn't in my curriculum. And I had the chance to do some ERCPs by myself, alone. I wanted to improve my skill in cannulation mainly, and holding the scope in a position during the ERCP mainly. And thank you.
So how many independent have you done?
Less than 10 cases, yes.
Okay. Great. Well, you are the first international candidate, and because of you, we've extended this from 5 to 6.
Thank you.
No, you're welcome.
Thank you.
Thank you for selecting, and let's hope you have a good experience.
I have a talk with Dr. Marwan, a short talk. We are from the same country. I live in Jordan, but he lives in Gaza.
Yeah.
My family, my uncles lives in Gaza.
Oh my God.
Yes. Thank you.
So,
Thank you.
Our hearts and our.
I hoped to meet him, but he told me he.
No, he had to rush.
Yeah. Yes, he went in a rush.
Yeah, he had some issues in the family side, but.
Thank you. Thank you.
I hope you have a good time. Dr. Fahad.
Doctor.
Thank you, sir. Sir, I've done less than 10 procedures independently. I've assisted a couple of ERCPs. Sir, my prime impediment is cannulation. I would like to learn the cannulation.
Okay. Great. And you are from?
So I'm from Pakistan Army, sir.
We have to be careful, guys. Okay. But you are in Mali, right?
So I'm a Malay, sir.
Mali doesn't have a fluoroscopy facility.
Sir, it has a fluoro facility available in OT.
Okay. But if you want to, you can actually
Sir,
go ahead.
go ahead, sir.
Good. Daud.
Assalamu alaikum everyone. My name is Dr. Daud Ghilzai. I am from Bolan Medical College and I am assistant professor in Department of Gastroenterology. I did assisted ERCPs at least 50 and at least 20 successful ERCP in my private setup. And in that I have placed stents and extract stones and sweep balloons and all that. Thank you.
What is your aim?
My aim is to improve my skills, my positioning and stabilization of scope during my procedures is all that.
My name is Dr. Ali Kadir. I'm working as a consultant gastroenterologist in Indus Hospital, Lahore. So in my campus, we have basic facility for endoscopies, for colonoscopies. We are doing diagnostics and therapeutic. And inshallah, hopefully in a month or two, we'll be starting ERCP over there as well. So I've done almost like close to 100 cases under supervision and have observed more than, I think, 400, 500 cases. My aim to actually come here is not, it's not very specific. It's general. I need to learn everything which you guys can teach and to improve my skills overall generally. So that's it. Thank you.
Assalamu alaikum. I am Dr. Vikas Ahmed. I am currently working at Hyderabad Medical Complex, Peshawar as specialist registrar. So I have done different steps of ERCPs. Like initially, stepwise, I have done intubations more than 50, then cannulations in papillas where ERCP was previously done. I have done like 10 to 15 cases completely, but that was under supervision. So my primary focus here is to improve my effacement of papilla, do cannulation in native papillas, and learn sphincterotomy in appropriate way. Thank you.
Very interestingly, 5 of you want to focus on cannulation. Cannulation, as you will be told, to make your cannulation easy, there's only one thing, and that's position, position, and position. Okay? So once you've got your ampulla at the right position, then cannulation will become relatively easy. So we have 4 observers here as well. We don't give any hands-on experience. Let me clearly say this up front, because it's not possible. The aim and objective of the course is to focus on these hands-on. And to be able to give you any hands-on it would take time from them. So I apologize, because a lot of times when you're giving us feedback, you want 1 or 2 cases, and as much as we would like to, it's not possible. But other than that, I think in the next 3 days, I learn a lot. In the last 8 courses, I have learned a lot of things. Improved a lot of things. So it's just by watching, just by being here, I think there is a lot of learning. So hopefully you'll learn. Naval, we are now, where is Dr. Naval? Yeah. We are going to our aims, objectives done. So we already have that, and so we'll just go straight to the, Dr. Shanil, sorry. Dr. Shanil Kadir is going to introduce something that he has been involved in.